Good afternoon. We have with us Dr. Khalid Mohammed, the Associate Consultant at BLK Max Hospital, New Delhi. Doctor, we welcome you to the Natco Pharma Studio, and we look forward to discussing with you the critical care space and also bacterial resistance. What are the changes you have foreseen in critical care management?
Okay. So nowadays we are seeing that the most of the younger generation and the nursing staff and all they don't follow, and the senior doctors also they don't follow the hand hygiene, and for that reason there is a lot of contamination and the patient is getting infections. Cross infections are there from one bed to the other. So we need to stick to the hand hygiene and the strict asepsis environment to tackle with the patients and all. And the next thing is that we should have a clear knowledge about the antibiotic stewardship. Like we need to start with the prophylactic antibiotic or the empiric antibiotic, and then we need to switch to the targeted antibiotic after the culture sensitivity is there. So this will lead to the avoidance of the MDR bugs. So we can come over the MDR bugs if we just stick to the antibiotic stewardship. So we need to have a clear cut knowledge about the antibiotics, their groups, their mode of action, the gram positive, gram negative, antifungals and antiviral. So we should have a good knowledge about it before starting any antibiotic. So we should be updated about it, and there are a lot of MDR bugs which are coming. So we need to deal with them accordingly, according to the resistance patterns and then all. We need to know about the resistance mechanism and how they act. So that is the main thing we need to know. So this will come with the experience, and if you keep on reading the new articles, new journals, and the new researches which is going on, and knowledge has to be upgraded gradually, and it is a day-to-day process. Like every day, you need to get updated. So this will help you in becoming a judicious and good intensivist, where you prevent cross infection in the patients, and this will also decrease the financial burden on the patient. So this has to be taken care of.
What is the message to your colleagues in the ICU who are in patient care? What would you like to tell them?
Like I will like to tell them that I've already told that they need to follow the hand hygiene and sanitization and strict asepsis before every procedure, handling with the catheter, handling with the central line, arterial line. So they need to follow the strict asepsis procedures to be done. And antibiotic, they should be have a first clear cut knowledge about the mode of action, the group, and the resistance pattern about the antibiotics and the bugs. And this will help them in deciding the antibiotic which to be started and the cultures. And they should daily follow the medicines and the antibiotic. Daily, they should daily assess the antibiotic which is going on according to the following the cultures and all the things which are the procal level to de-escalate the antibiotic. They should have a daily round should be thorough with all the antibiotics and the medicines which is going on. They should assess everything daily.
What is the prevalence of carbapenemus in your practice?
So we find a lot of carbapenem resistance bugs in our ICU. Actually, we find Acinetobacter, we find Klebsiella. So there is a crab like carbapenem resistant Acinetobacter. We have Klebsiella, we have Pseudomonas. So they are all mainly carbapenem resistant. So for that, like for Klebsiella, we go for the resistance mechanism. We send for expert carba panel. So they will show the resistance mechanism, whether it's the OXA 48 or NDM, and accordingly we could start ceftazidime avibactam with the estunum. So which has to be decided. And if as crab is there, like carbapenem resistant Acinetobacter baumannii, we go for the triple therapy. Like we have a carbapenem, along with that we have a colistin or a polymyxin B, according to the creatinine and the bug which is infesting. Okay, whether it's a urine or a blood infection, bloodstream or a tracheal secretion, and then we add a sulbactam. So this triple therapy helps in overcoming the crab. So we have a lot of carbapenem resistant bugs in our ICU, and it's increasing day by day because of the maybe it's due to the our factor, the doctors and the paramedical medical staffs are not following the strict asepsis, what may be. So we are giving the bugs to the patient through, if some patient is having, it is being transmitted to the other patient. So we need to think over it, and we need to follow the strict asepsis, what I feel. hand hygiene and everything. So we have to take care of it to avoid the financial burden on the patient also, because this is causing a lot of financial burden. If the patient is having a crab or something, the 10 to 14 days stay is increased in the ICU. So it's obviously causing the financial burden on the patient.
Thank you for sharing the treatment options as well. And Dr. Khalid, you have spent your valuable time. We wish you all the best on behalf of Natco Pharma Specialty. Thank you so much.